This conference will now be recorded.
Good morning, everybody. I'm Kyle Martin. I'm the Associate Director with the North Dakota Center for Nursing, and our Executive Director, Dr. Patricia Moulton, is on the call as well. I'd like to thank everyone for joining us this morning. I know this is a really trying time for nurses in recent memory, and so we thank you all for just being here, and we hope that everyone is well this morning. I'd like to express first my gratitude to Mylynn for joining us this morning. It is just a hectic time for everybody right now who's working just to keep North Dakota healthy. So, Mylynn, I just want to express my gratitude for you joining us this morning. I'm so happy that you could join us. Mylynn is the North Dakota Health Officer. You've seen her during Governor Burgum's press conferences, so she's been working tirelessly for North Dakota's health and well-being. Originally from Michigan, Mylynn began her career as a critical care nurse and was an RN for over 10 years. With that said, thank you again, Mylynn, for joining us. And just a housekeeping note this morning, please mute your phones so that we can avoid background noise on the call. And if you have a question you'd like to ask, if you're joining us via the web, you can also enter your question into the chat. We can try to get to it that way, but we'll also open it up for questions here at the end after Mylynn begins. So on that note, again, this webinar is hosted by the North Dakota Center for Nursing. And just to break, I'm gonna get my PowerPoint here going. A little ahead of myself. Yeah. Okay. So that said, Mylynn, I'm going to hand it over to you. And thanks again for joining us.
Great. Good morning. Thanks for everyone who's joined us today. And thank you to Kyle and to Dr. Moulton for this opportunity to talk with you. It is very much unprecedented times that we are living through, and I want to also express my gratitude to you for all that you're doing to support this COVID-19 response. It is an overwhelming endeavor that we all are playing a part to make a difference in the way this virus plays out here in North Dakota and across the country. So with that, my gratitude, and I think that as a nurse, I know firsthand the role of nurses and the leadership that nurses bring to this fight. So I thank you for that. I didn't prepare a presentation today, but there were some things that I wanted to talk with you about related to COVID-19. First, I wanted to talk about that testing and identification of individuals that have tested positive for COVID-19. I wanted to talk to you about contact tracing and how that plays a part in us flattening the curve. Third, I want to talk about the medical surge and medical surge capabilities within our healthcare system. And then lastly, I want to talk a little bit about recovery, because we're all very hopeful to get over this hump and pass through this virus and see what we can do to get to the other side and get our lives back to normal. So I know there's a little bit of background noise.
I'm going to just remind everyone, if you're on the call, if you could yourself, we're getting a lot of feedback from other people's phones.
So on testing, we have completed testing at levels of about 15%, and that's still not enough. We've had to prioritize individuals based on symptoms, based on exposure, and our healthcare workers to make sure that we were using our tests appropriately. As of last night, we had over 2,000 tests completed with 58 positives and 11 individuals that have been hospitalized in COVID-19. So there's a lot of work that's being done to increase our capacity for testing. And what we've learned is there are two limiting factors that have occurred related to testing. They were on the collection end, and they're on the back end laboratory reporting side. On the collection end, this is a nasopharyngeal swab, and the individuals that need to collect this or are able to collect this had limited swabs available. In addition, the emphasis on making sure that people presented themselves in a safe manner for our healthcare workers was very important. So that's kind of on the collection end, some limitations that we've had, and we're going through ways to improve that, looking at other collection methods like a nasal swab versus the nasopharyngeal swab, getting some supplies from our neighbors in South Dakota, and then receiving some federal assistance by helping increase our supplies of these nasal swabs too. On the resulting end, the laboratory end, the capacity for that was somewhat limited as well. So there's these testing reagents that are used by our lab and other labs for results. And those reagents and kits for the lab have been very hard to come by. So we've been scouring the nation, scouring all of our different suppliers to make sure that we have enough testing capability in our lab to meet this demand and get people tested. Over the last week or so, our national reference labs have come online. These are the LabCorps, the Quest, Mayo, ARUP. They have come online with testing capabilities. One of the things that we've experienced is that
this is all audio. I
that
don't have any other way to listen online to the, and it's very scratchy. Does your phone not work?
sorry, there's someone that's still talking.
You haven't.
I'm not on mute. So the reference labs have had a lot of backlog, and they are processing the test results, but it has taken more time than, say, a 24-hour turnaround. So as you leave testing, we begin the work that happens within public health. And in public health, our epidemiologists have been doing a case investigation and contact tracing. In that case investigation, we have epidemiologists that reach out to the healthcare provider who has conducted the tests, letting them know that this individual had tested positive. Then we are able to reach out to the individual patient and let them know that they have tested positive. I think that their provider typically is the one that notifies them. Then we conduct this thorough investigation about who they've had contact with, when did their onset of symptoms occur, what symptoms did they have, how are they doing as far as self-isolation, and how are they doing right now. So we give them instructions and then begin the contact tracing of their close contacts. And close contacts in this scenario with a respiratory droplet virus, we are looking at individuals that have been in close contact greater than 15 minutes at 6 feet distance, so that really close contact of individuals. So the contact tracing occurs, and then based on that exposure, we know that there are individuals that are that we reach out to, that we want to test, that we notify, and then we tell to go into isolation and quarantine themselves. So that all happens here at the Department of Health within our local public health offices, as well as we're bringing on additional nurses to help us with that contact tracing.
Oh.
The next category I'd talk about related to COVID-19 response is the work that's being done to prepare for a surge of patients. And we know that we're trying to flatten this curve so that we don't have a huge spike of patients that impact our healthcare system and overwhelm it. So we've been doing an analysis on different modeling scenarios. We've been doing an inventory of hospital beds, long-term care beds, and our healthcare providers that are able to be a part of the surge planning. We're gathering that inventory. We're trying to better understand what capacity they have from a workforce perspective and what capacity they have from protecting their workforce related to PPE, that personal protective equipment, the gowns, the gloves, the N95 masks, those things that are going to keep our workforce safe. So we've been doing modeling, we've been doing an inventory, and then feeding into a plan for how we handle and prepare for a surge. So that all is happening, has been happening because we know individual hospitals and healthcare systems have a pandemic plan. We know that there are communities that have been participating in preparation for the place that we are now. So that should leave you in a good feeling that it isn't like we're just dusting off the playbook today, but that people have been working hard and being very thoughtful about what COVID-19 could mean for North Dakota. One of the things you may have heard the governor talk about is a strike force or a rapid response team. And we've been thinking about how that might play out in our state, given the large geographic boundary of our state, the spread between or the distance between our hospitals and where our citizens live. So we came into COVID-19 with concerns about our workforce and the number of people that we have in the workforce. We came into COVID-19, this pandemic, with concerns about our rural nature of where we live and the distance or access to healthcare. We came into this COVID-19 pandemic with healthcare disparities, and those things haven't gone away. They're still there, but we're working very hard to be innovative, rely on the assets that North Dakota uniquely has through collaboration, through knowing their neighbor, through not having a lot of bureaucracy in the system. So I think that there are challenges that we came into this pandemic with that we understood, and there are challenges that or opportunities that we have in North Dakota to really make a difference and have, I think, hopefully a different outcome. The last part that I'd talk about is recovery. And we've been talking about a whole of community response, a whole of government response. As I said, this epidemic is constantly changing and evolving. We need everyone to work together. Everyone has been impacted by COVID-19, whether it's the healthcare workers, the teachers, the students. I can't name a community member that hasn't been impacted by where we are today. We are, just as we're planning for a medical surge, we're also planning for recovery. And there are many people inside the state government, as well as our private sector partners, that are looking at how do we come out of this with less economic damage and less loss of life. And there are a lot of people that are focused on minimizing that damage and trying to get resources to individuals that need it the most. So with that, I would tell you that Here, I'm at the State Emergency Operations Center with a team of people from our Department of Emergency Services, from our Department of Health, from our National Guard, to every agency within the whole of government that have put their resources together, that are part of a team to help us best prepare for this pandemic, as well as minimize the loss of life. So thank you for all that you're doing, and I am so proud of the leadership that nurses are playing in this fight. Kyle, I'll be happy to take questions or
Sure.
go into one of those areas that I didn't talk about that maybe people have some interest in, or
Sure.
whatever might be on people's mind.
Well, I'm going to ask too, if you wouldn't mind. I know at the very beginning we reach maximum capacity, which is something we don't do a lot on these calls. We have probably about 300 people now, and so we had a lot of people. We were trying to get people muted without muting you. And I'm wondering, could you just repeat your opening part, because I think a lot of people had a hard time hearing that.
Okay, so my opening part was that I have a lot of gratitude for nurses being on the front line of COVID-19. I know that you're leaders. I know that you've been involved in so many different aspects of what we do and in our communities, at our healthcare settings, and leaders within your own family. That is going to be so important as we move through the next couple weeks and months. I talked a little bit at the beginning just about some of the things that I wanted to go over around testing, contact tracing, making sure that individuals, once they've been identified as someone that might have traveled from an area that has well-known community spread or outbreaks, these hotspots, that they isolate. Then I was talking about kind of the second phase being medical surge for healthcare workers. And then third, I had just finished with recovery. Kyle, does that cover the beginning?
That was fantastic. So I think just for those that want to ask a question, I know this is difficult, but given the amount of people we have, if you do have a question, I would ask that you put it in the chat. That way then we avoid having everyone unmute their lines at the same time, which is, a lot of background noise. So while we're waiting for some chat questions to come in, Mylynn, is it okay if I start with the first question?
Sure.
So one of the things that I have been fielding calls from, I know I've forwarded a couple to you as well, is the availability of adequate PPE in North Dakota and masks in hospital systems. And my question for you is this a widespread issue in North Dakota? What is our state doing to ensure that our nurses and other medical professionals have adequate protection in place? And for those nurses who might be on the call right now who don't have access to PPE, what should they be doing?
Great. So the question is about PPE and who has it, who needs it, and how can they get it. So the personal protective equipment that we've been very much concerned about are these N95 masks. And coming into this pandemic within the state, we were very well positioned from a N95 mask, surgical mask perspective. So within the state government, as part of emergency preparedness and our public health preparedness program, there's something that we refer to as the medical cache. And the medical cache, if you've been in a worked in a long-term care facility or a hospital, if you had an emergency where maybe your generator went down, or maybe you needed a piece of equipment or some supplies, you could order this through the medical cache to get it delivered in a very short period of time. So through the different years and funding through these programs, through our federal government, we have built up a store of N95 masks. We had a store of surgical masks, gowns, and gloves. So we came into this response in a really good position. One of the other tactics that Tim Wiedrich, who works on our team here, who has been the mastermind of our emergency preparedness program, had made an investment in something called PAPRs. And PAPRs are these purified air recyclers. And you see them as maybe a big white mask that goes over your head. Those have been positioned at our hospital systems as well as within our EMS providers. So we have a couple different lines of PPE that we have in the community and at our healthcare providers. One of the other things that we've been doing to help manage the PPE is to try to inform the public about who needs it and how it's best used and how to present themselves to the healthcare system so that they are not exposing our healthcare workers. So just that type of information is really important for everyone. So the next part is, how do you get PPE if you don't have it? Our healthcare providers, the hospital systems, they've been great in meeting with us to talk about their inventory, and they have capability to order within this warehouse system. I joke that it's kind of like Amazon, but basically they put in an order, we fulfill it here, and it gets shipped out. So that is the way that happens for our healthcare providers, the hospitals, the clinics, our EMS providers, our long-term care facilities. We've been working with those stakeholders to pre-position PPE so that even though we know that people have some inventory, we want to make sure that they have additional when they need it. I think you asked one other question, Kyle, that I might have missed.
You know, I think I did too, but there's actually a really great question that came in that I want to jump to regarding PPE. This is from Amy, and she's, or I'm sorry, not Amy, Tammy, who says, I work in a very small clinic. Is there any guidance on curbside testing as far as doing PPE and disposal? I feel like we should make efforts to not bring the used PPE back into our facility.
That's a good question, Amy. I do not know that we have given any guidance out of the Department of Health or that comes to mind yet from the CDC about disposal of PPE after it's been used. But I can look, as well as, you know, we rely on guidance and recommendations from the CDC and the field of epidemiologists that have been working on this pandemic since the beginning of January. So off the top of my head, I don't have any specific guidance about that disposal portion. As far as the drive up, all of our large hospital systems, they don't necessarily, I wouldn't call them the drive up, but I would say that they have a clinic or a facility outside of their emergency room where they are screening individuals prior to coming in and then receiving them in a very safe manner to not expose other people that might be within the hospital system. We are working and have a plan that we were given from FEMA to stand up, drive up facilities, and we are working that plan with FEMA, that when the resources should come available or those necessary equipment that is available, that we'll be able to deploy that in areas that may not have readily access to a healthcare provider for testing.
One of the other questions, Mylynn, that I've been seeing is I've had a couple people ask if you could repeat the definition of close contact.
Sure. A close contact in our contact tracing is someone that you've had contact with for more than 15 minutes within that 6-foot space. So that when we talk about social distancing, we here in the Capitol, as well as throughout, we've been talking about social distancing and keeping that space between one another. If you're out walking, or why it's important to have less than 10 people in a room or at a gathering. And it's really that space that's around you where you could come into contact with those respiratory droplets. So more than 15 minutes and within that 6 feet space.
Awesome. And I'm going to jump on that as well, because we're getting a lot of questions that seem to be related to each other. Another different Amy asks, if one long-term resident tests positive with all those who were in contact with the resident, should they be tested, or do those who have to show symptoms prior be tested? So I think she's asking if you're asymptomatic, should you still be tested if you came in close contact? If you're or are you testing only people with symptoms? And then secondly, if not, are we concerned that those in contact don't show severe symptoms and end up being carriers?
There's a lot there. Number one, yes, we're concerned about asymptomatic spread of disease. And that's why people have gone to shelter in place. That's why we have put in restrictions related to mass gatherings. That's why we have some of the restrictions that we see today. So the answer to that is yes, we're concerned about asymptomatic spread. And then related to long-term care, if you've been following the news, or and the coverage is expansive. What happened in Kirkland, Washington is everyone's worst fear. So for long-term care residents, we have at the Department of Health, we have a survey team. We've gone out and done some surveys around making sure that the practices for protecting workforce and patients is in place. And over a week ago, I don't know the date exactly, the long-term care facilities had closed their doors for visitors except for under essential visits, such as end of life or critical events. We have had individuals recently in a long-term care that have tested positive or concerns about testing positive. They go into isolation, and then as we're doing that case investigation, we understand who came into contact with a resident and how much exposure they might have had to this individual. So should you be tested? It probably depends on your exposure to the individual that has tested positive, how long, the duration, and what kind of behaviors you might have, interactions you might have had with that person. So should people that are asymptomatic be tested because they are in close contact? It depends. If you are a healthcare worker that may have some underlying illness, if you had, maybe you're in a high risk group and you're a healthcare worker, I think that we've been trying to give guidance to our healthcare providers, as well as during this case investigation, about who should be tested as a priority. But we do want everyone, I pray for a day that everyone who wants a test, especially our healthcare workers, are able to get that test.
Great. And another question on testing, as I'm getting more that are coming in. My friend Julie from the Dakota College nursing program wants to ask, if a person tests positive, do they need to then test negative before they can go back to work? And what is the timeline?
So the question about do they need to test negative before they go back to work is probably up to their individual employer. Our guidance is they have to be symptom-free, more than 3 days without any fever-lowering medication, and it has to be greater than 7 days from the onset of symptoms. So do they need to have a confirmation negative test? The answer is no. I would say if a healthcare provider had asked for that test to be done, and it came to our lab, we probably would do it.
Well, thank you for answering that. I'm getting a couple other questions. I don't know if you can answer these or not, simply because it might be in violation of HIPAA, but a couple of the nurses in the chat are asking if you can share at all with the people who are hospitalized, if you can share what their condition is, if they're stable or if they're critical, or is that a question that you can even answer?
Maybe. This has been it's been a challenge for us at the Department of Health, as well as the government and the public, to want information, and then also the balance between the privacy of an individual that has an infectious disease. So we've tried to adhere to the standards that are least identifiable to the individual, giving an age range, giving the sex of an individual, and then the county where they reside. And that even has caused some stir about the county that they reside. The individuals that are hospitalized, they range from a variety of ages and from the age ranges that we've let people know that they've tested positive. I would say that they are in 3 out of our 4 largest hospital systems right now. They all are right now, I believe, located in an intensive care unit, and that level of care and where the negative pressure rooms are is probably why they're there. There are individuals that are in critical condition, and we know, and we've tried to express to people that we have a very long-lived population in North Dakota. Our number of residents that are over the age of 60 are 20% of our population. And then when you add on these chronic underlying conditions of diabetes, heart disease, those things, kidney disease, we have a fair incidence of people with those chronic underlying conditions as well. Individuals that are immunosuppressed, individuals that live in congregate settings. So those risk factors are front and center of how we're trying to protect these vulnerable populations.
So Mary wants to ask, are there any guidelines for masks that people are sewing to help facilities?
I have not seen the exact guidelines, but I do know that there are a lot of people that have that skill and talent. I've heard that there is I'm thinking plan, but I know that that's not the word for sewers, where you could make these masks. And here in the Bismarck area, I know there's a group of individuals that are sewing these, and they're going to deliver them to nearby hospitals and other workers. The thing about a mask in a healthcare setting, a cloth mask, the guidance is that they need to be cleaned through an autoclave. So if we were really looking for that sterility or that level of protection, we want to make sure that they would be able to be cleaned effectively. So I hope that answers your question.
And another question that came in through the chat is, and this kind of goes back to what we visited before about symptoms and testing, but this is a question from a nursing student. What symptoms need to be present for a healthcare worker to not be allowed to work? Is fever the primary symptom?
There's different things other than just symptoms. So first I'd start with, if you've traveled from one of these high risk areas and you just came back to North Dakota, I think that you should consider some self-isolation or monitoring of symptoms. I know that we recently put out guidance for our healthcare workers around exposure and what to do. Let me repeat the question too, because I think I lost the last part of it.
That's totally fine. So she just asked, what symptoms need to be present for a healthcare worker to not be allowed to work? And is fever the primary symptom that you're looking for?
Yes. So the symptoms are the same for anyone that might have contracted COVID-19. Fever is the hallmark symptom that we're looking for because it's easily quantifiable, and we know that that's one of the primary symptoms. In addition, for healthcare providers, we've listed some other symptoms that they might have, such as cough, shortness of breath, sore throat, chills, myalgia, fatigue.
So I also want to jump to a question that I got via email, and this is from actually one of my friends at the VA. And she's wondering, how do we treat tubing from CPAP, nebulizer, nasal canals, etc., for those veterans who are under investigation or who have a positive test?
That is probably out of my league as far as the definitions related to those protocols. Could I take that question back to our disease control team and see if we have existing guidance or that we could help answer that question?
Yeah, absolutely. In fact, since I have this one in email, I will get a hold of this person, just make sure she's okay with me forwarding it to you. And
Okay,
I
that'd
can.
be great. And we talk about, it's definitely different for that type of equipment that you're talking about, how best to clean that. For individuals that have contacted us or potentially very concerned about the coronavirus living on surfaces, that information that we have it came from SARS and that coronavirus, knowing that it could live on surfaces anywhere from 3 days to 9 days, depending on the type of surface, depending on the conditions. And that's why we've emphasized that proper hand hygiene is so important, and not to touch your face. Those things we know, if you clean with the cleansers that they have at hospitals and long-term care facilities, if you use those antibacterial cleansers, if you use the Clorox bleach wipes, that all helps kill this virus. So there's a lot we can do, and some of it just starts with a good hand hygiene for our public.
Another question I received via email was that some of the people, this is a person that works in a healthcare facility, who said that they're getting emails from people or calls, and it sounds as if that these people are probably positive based on their symptoms, but they're telling them to not come in to get tested. They're asking them to just stay home, and they're worried that those number of cases aren't being represented in the daily graphs and charts that you guys are putting up on ND Health. And so they just wanted to know what your thoughts are on that. Are you guys assuming that we do have more positive cases in the community that simply haven't tested, or what are your thoughts on that?
So yes, we have heard that there are practitioners that have talked with their patients and went through symptom checkers and how this individual might be feeling, and said, you may have COVID-19, you should isolate and stay home until you get through the symptoms and that waiting period of isolation, or until your symptoms progress. So yes, we have heard that. We are concerned about these presumptive positives that we do not know about. We're in the process of trying to gather that information from the public, should they share that with us through a survey that we've been working on, so that we have a better feel for who might be presenting to a healthcare provider and not showing up in the numbers that we provide, because the numbers that we provide are only people that have been tested. The other reason why we want to know about these presumptive positives is we want people to, one, self-isolate, and then two, think about contacting individuals they might have come in contact with, and then also maybe jump-starting our investigation of these close contacts should they get tested and then result positive. So I hope that answers your question on presumed positives. It is a concern of ours. In the modeling that we're doing, we have looked at prevalence of COVID-19 across our region, compared to other states, compared to the country. So yes, we're looking at our actual numbers, but then we're also looking at prevalence rates for COVID-19.
Another question that came in and I've actually been seeing this a lot on social media. I know social media can kind of be a dangerous thing when you're dealing with an epidemic like this, because there can be a lot of misconceptions out there. And the question that we received was, do you have any guidance in terms of just treating yourself at home? Is it safe to take acetaminophen? Is it safe to take ibuprofen, or should ibuprofen be avoided?
So I know that there has been some concerns about use of ibuprofen for symptoms, and there have been some studies that we've looked at. We haven't seen conclusive evidence around the use of ibuprofen. I do have a group of advisors that have given us guidance, and they said for them, they would first recommend the use of acetaminophen, the Tylenol, and then if that doesn't work, move to the ibuprofen. And that's what I'm hearing from my advisors, and I don't think that there's scientific evidence that ibuprofen is an issue.
Another person that asked a question is, if you test positive today, how long before, or typically how long are symptoms lasting in people who have tested positive, and typically what is the recovery time?
So people that test positive today have different background statuses of health, and it depends. We know from looking across the country and across the globe that the majority of people that get COVID-19 have very mild to moderate symptoms and that don't require hospitalization. Those could, depending on the time that these symptoms present themselves, I've heard anywhere from 5 days to 14 days. Some are very mild, and maybe like 3 days that they felt like they had the flu. So it probably depends on the individual. As far as the more severe cases, what we're hearing from other states related to the course of care and the length of stay for individuals with COVID-19 has been prolonged. So potentially upwards of 2 weeks in the hospital, If they were severe or critical, they may be on a ventilator in excess of 7 days. So as we're learning more about COVID-19, we know that it's a severe respiratory syndrome. It presents a lot like pneumonia in its critical stages, and depending on the underlying conditions of these individuals, their course of treatment is more prolonged for them.
The next question is, if I work in a hospital and I have someone who is immune compromised that lives in my home, and I'm still taking precautions regarding just proper PPE and hand washing, do I still pose a risk to those living in my home that may be immune compromised?
That's a hard question. It's possible because the level of community spread in an area where you're not able to trace where you contracted the illness from has made that maybe a little bit more challenging and adds to the risk. So areas that have community spread and a lot of community spread, that does add to the risk factor. Doing all the things that you've said around using PPE, those proper hand washing and isolation and hygiene tactics, I think minimizes that. The social distancing, that time that you spend with that individual in close contact will help minimize that risk. And so for this individual or other healthcare workers that are concerned about that, I think that you need to talk to your provider or your employer and advocate for what's best for you and your family.
So Jackie wants to ask, could COVID-19 possibly hide behind another illness, such as if they presently have influenza, could they also have COVID-19?
Yes. And when we were very short on tests, we would say rule out influenza. If you had influenza, then treat yourself like you had COVID-19, stay home until your symptoms minimized and that or went away, and then you were free of that illness. So there are individuals that do present with those mild symptoms and may just feel like they have flu-like symptoms and may not seek a provider to get confirmation.
Another question is, someone is kind of looking for some guidance on what is considered a hotspot. So, and if a person has traveled, how do they determine that they were in a hotspot, and should they isolate upon their return?
So what's a hotspot? We've utilized the CDC guidelines and recommendations related to travel advisory countries. We have now understood that there are hotspots within the country, New York, Florida, California, around the LA area, Seattle, and the Washington area. They've all shown themselves to be hotspot areas. I think New Orleans is another one. Those areas where the number of cases and the amount of community spread has grown in such a substantial way over the course of the last several weeks. Those would be areas that are concerned and we would consider hotspots. We are in the process of trying to limit, or will be limiting, individuals that have traveled internationally or out of state to self-isolate or quarantine for 14 days. And if you were in close contact with a named individual and you have been told that you need to self-isolate, that would also be our order to stay at home until these 14 days have passed.
Another question that we received is, and I'm not sure if you can answer this or not, it's a pretty technical question. Is there an algorithm for COVID testing for patients that are being admitted to the hospital that do not have any respiratory symptoms or a fever?
There's not an algorithm for patients that are admitted to the hospital that are asymptomatic. We've left that to the provider's discretion based on that individual's past history, their close contacts, kind of their own individual situation to make that determination.
So going back to just the amount of cases in North Dakota, where does the United States, or where does North Dakota stand in terms of other states? Are we seeing a greater amount of spread compared to even like our neighboring states? This is Montana, Wyoming, South Dakota, Minnesota. Do we have an estimate where we think this will peak in North Dakota?
So for where we stand with our neighboring states, we know that we're several weeks in this virus progression behind Minnesota. We know that we're about 1 week behind South Dakota. We know that Montana has community spread that's been documented. And we've looked at kind of that case rate infection. But one of the things that we are taking into account is the level of testing that's occurred. We know in South Dakota there was a period of time when they weren't testing because they didn't have supplies. So you have to factor the number of cases in comparison to the number of tests, and that's something that we're considering. As far as do we know when the peak is, we've been modeling that, and we really need, according to our scientists, we need at least 10 days of data to really understand where that peak might come in. In addition, what's the impact of the measures that have gone into place, the closing down of universities or moving them to an online modality, the closure of schools, and then how they might have impacted the flattening of the curve, the closure of businesses or restaurants and those mass gatherings. So all of those factors play a role in the modeling, and having the true experience of cases and tests is going to determine that peak. Our first case, I believe, was around March 13th. So we're right now, according to our model, tracking, but it's still early, and I can't tell you that peak number yet.
So Cassie is asking, the CDC is recommending contact plus droplet precautions plus goggles, unless performing an aerosolization procedure, yet many facilities are having workers wear N95 masks all the time. As a nurse, do you believe paper masks are sufficient, or should we be wearing something else?
So the CDC's guidelines start with, I think, the best protection, and then they also give the flexibility to say, if you don't have this PPE, if you don't have this level of protection available to you because you don't have any stock of N95s, then use your next best defensive mechanism. So for us in North Dakota, we feel that our healthcare workers should use N95 masks, and if they're coming into the contact with those respiratory droplets, or could be, they should have protection over their eyes. So yes, we have even given guidance in our healthcare recommendations that individuals that are healthcare workers could wear a surgical mask if that's available to them and they feel more comfortable to do that.
Another question we had was, should practitioners be giving presumptive positives?
That's a hard call. For many, 80% of individuals that could be presenting, their course of treatment would be the same if they were confirmed positive or not confirmed positive. Self-isolate, monitor your symptoms, stay at home. So whether you have the confirmation of the test or not, the guidance that you would be getting would be all the same things. Knowing you have the symptoms and the actions might encourage other individuals to take it more seriously, to do the self-isolation, to have some other individuals reach out and do the close contacts. That would be one of the data points that I think that we're missing on the presumed positives. Understanding how many people have been given that guidance that they were presumed positive, and then that self-isolation and close contact tracing.
So Rachel wants to ask you, do you have any information on how nurses not currently working in the hospital setting can still help their local hospital should there be a need? Who can they contact to lend a hand?
Yeah, that's a great question. Recently, in an executive order, the governor had allowed for the Department of Health to recognize the licenses of nurses that were licensed and in good standing from another state. So that is, if that's someone that you know or you qualify for that category, there's a place on the Department of Health's website to submit that information under the healthcare provider tab. For nurses that are maybe retired or have been out of the workforce for a bit and want to get involved, there are many different places that you could. The Board of Nursing is looking at ways to activate student nurses as well as retired nurses. And I can't speak for how the Board of Nursing is going to handle that, but they are looking for ways to bring these our fellow professionals into the workplace. As far as volunteering or just being a leader in your community, because of your background and knowledge, you can help us educate. You can help us stem the fear, help people understand the importance of the practices that we're talking about around self-distancing, self-isolation, hand hygiene, those things that are so important that they might not understand the why. In addition, there's the medical Reserve Corps that is instituted. I know that we have nurses that are part of that. That's through the Department of Health. You could register yourself as part of the Medical Reserve Corps, and we have deployed nurses as part of the Medical Reserve Corps when we've responded to other emergencies across the country, such as hurricanes or the measles outbreak in Washington. So getting yourself registered in the Medical Reserve Corps is another area. Contacting your local provider and letting them know that you're kind of in the reserve or wanting to help could be another way. And then just being cognizant that you might not be the best person to be on the front line if you had pre-existing conditions or one of those vulnerable populations. So just trying to understand how best to contribute in a way that doesn't put you or others at risk.
And I'm going to piggyback off of that. One of the questions I got was, should healthcare workers with pre-existing conditions stay away from the workplace?
I think that is a concern of ours. And, depending on your place where you work, it will depend on how much exposure you have. For us, even our workforce, we've moved a lot of them to work at home. So it depends on your job and what your level of exposure is. So I can't give a blanket statement. I think that individual should talk to their employer.
Sure. Well, I know we're almost reaching the end. Do you have time for maybe one or two more questions?
I have time for maybe one question, and then I need to head to my next meeting.
Sure. So I'll just wrap up with this. Mylynn, what do you know about COVID-19 today that you maybe wish you would have known 2 or 3 weeks ago?
It's a tough question. What I've learned from today is the impact that everyone's actions have on how this disease is spread. So knowing that we have to combat the bad information and the individuals that are not taking this seriously has been as much of a challenge for us to get the right information out to individuals as combating the disease. So it's somewhat a dual prong battle that we're facing, managing COVID-19 and then managing the viral false information that may be out there on social media and the internet that has prompted people to think that this won't impact them and that they can go about their lives.
Well, with that said, I'm getting a ton of questions in the chat, not even questions, just thanking you, Mylynn, for joining us today. We so appreciate it. I'm still getting questions, and we may have to either set up something where we can email you these questions, or even just do just like a one-on-one video call so we can avoid some of that feedback that we had at the beginning. But again, I just want to express my gratitude to you and to the governor and everyone at North Dakota Department of Health for just everything that you guys have been doing. It's just been phenomenal. The daily updates that we're receiving at 4:30, it's just been great information for us citizens to have. So again, please just pass on our gratitude to everyone that's on your team, as well as express our gratitude to the governor. We really appreciate you just taking the time today. We know how busy you are. So thank you so much for joining us today, Mylynn.
Thank you, and thank you for all that you're doing for our citizens to help save lives.
All right, with that, I want to thank everyone for joining us. That'll conclude it. And like I said, we can maybe look at having a more informal session to ask more questions that we're getting in. If you have questions, feel free to send them to the North Dakota Center for Nursing. We can always pass these on to the North Dakota Department of Health. And of course, a great resource for a lot of these questions that we've been getting is I would recommend going to the North Dakota Department of Health. They have a great COVID-19 center. We have piggybacked on a lot of that information and put it on our website at the Center for Nursing. We created a COVID-19 resource center. And of course, refer to that CDC guidelines. And for any additional questions regarding your work, I would suggest that you contact your employer as well. So thank you again. We'll see you soon.